So back to my presentation, don't forget to vote, because I shall say this only once. Double bundle is a perfect choice. Why is it so? We know that we need to define the playground, so the epidemiology behind it says that it's very rarely an isolated injury. It's usually accompanied by other injuries, so the main question is, what do we treat? Are we treating isolated PCL tear, or are we treating multi-ligament knee injuries? So the indication for surgery, obviously, in those multi-ligament knee injuries would be to repair everything, either in a single stage or two-stage approach, or in those patients who have really grade 3 instability and there are not good responders to conservative treatment. But I would like to define the playground where we play today, and it is the third point where we have side-to-side difference in posterior tibial translation greater than 8 millimeters, where we have isolated PCL tear. There, at that playground, we know that biomechanical results show that double bundle is much better player. There are good biomechanical studies published 10 years ago, and take a look at these results. Biomechanically, double bundle acts, this is the green bar with single bundle, and yellow bar representing double bundle technique. And when we look at the posterior translation, then it tends to be much better resisting posterior translation. And then if we take a look at internal rotation, then again double bundle tends to be much better from biomechanical perspective. How do we perform double bundle technique? So tibial socket is standardized preparation. We've seen that today. And how do we perform our grafts for double bundle? For anterolateral bundle, standard-wise, we use semi-T graft as an autograft, and gracilis graft for posterior medial bundle. And then we do suspension technique. We use tight ropes for femoral sockets and femoral part of graft fixation, and for tibial part, ABS tight rope. This is the way the graft is prepared. I will not bother you right now with the technique. So first we prepare the tibial socket, then we drill inside out anterolateral bundle. We tend to preserve 2 to 3 millimeters cartilage margin from the socket, and then we perform the second tunnel for the posterior medial bundle with retrograde drilling, and then we need to address suture management. It's very important, and then we first pass the graft through the tibial socket, then second anterolateral bundle, then PM bundle, and then we tension in the same sequence all these 3 sides of the graft. Suture management is extremely important with this technique, and this is how it looks postoperatively. So we use fluoroscopy throughout the procedure. It's very important to place good anterolateral and anteromedial portals. They need to be as close to the patellar tendon as possible in order to be able to get to the posterior part of the tibia. We use the PCL tibial guide to retract the tissue in popliteal recesses, and we really take care about our suture management. We need to avoid complications with sutures and avoid placing tunnels at the wrong positions, and then it's a straightforward procedure. And don't forget, when you vote, what are the advantages? It's biomechanically superior to single bundle technique. Don't listen to what Tassin is about to say. And the internal brace can additionally add to stability, and outside-in creation of the femoral tunnel minimizes then the critical corner angle. So we use that in our technique. and disadvantage. The only disadvantage is that the suspensory fixation has the risk, but my opponent will show you that he also uses suspensory techniques, so there is no disadvantage when we compare our techniques. Yeah. Thank you.